and speak. And at the same time, I request any questions that you may have, please type them in the chat box so that we can take them one by one, or maybe um, during the discussion phase of the webinar. Thank you. So we'll start in about I think 5 minutes from now.
Yeah, I think that sounds good, sir.
Yeah, sir. Good evening.
Good evening. How are you?
I'm doing very well. I didn't realize you had joined. Good
No,
evening,
I've
and
joined
thank you
already.
so much.
Yeah.
Sir. Thank you, sir.
Actually,
Thank you.
actually,
Thank
I
you.
am in the middle of my dukan.
Yeah. Oh, I see. Okay.
So
So nice.
that's the kind
Thank
of
you.
thing that's okay.
Yeah.
So we'll join
So,
after
like you
5.
said,
Yeah.
Hanji, like you said, we'll try and wind up by 9 o'clock,
Yeah.
maybe 5 minutes here and there, if at all there is some
Yeah.
discussion, and
Absolutely.
we'll try and keep it crisp.
Excuse me, sir.
Hanji,
We are
Hanji,
already
saying
live. So,
oh, we are live. Okay.
so good evening, everyone. I'm Dr. Amit Kumar Vyas from Jaipur. With the chairmanship of Dr. Abhijit Vahegaonkar, sir, we have started this IOA education program, uh, where we do uh, every twice a week, every 2 weeks, decision making in hand surgery. So today we are going to discuss about decision making in lower end radius. So lower end radius is a have there is this subject has enormously researched, and a lot of new innovations are there. So we will try to discuss all these things. So first of all, I would like to invite Dr. Abhijit Vaigaonkar sir to initiate this webinar. Sir.
Thank you so much. So I welcome everyone who has joined this webinar. It's being live streamed on YouTube as well. And I think this is a great opportunity for us to connect with each other, to learn from each other. And at the outset, I would like to thank the IOA leadership and the EC committee for giving us this opportunity and the responsibility of conducting these webinars. And extremely grateful and would like to acknowledge the JKOA for joining the cause. And I think it was just at the drop of a hat that Gani sir agreed to do this webinar. I'm grateful to Dr. Altaf Kavusa, who's the president, and Dr. Abdul Ghani sir, who is the secretary of the JKOA, for permitting us to collaborate with them. And of course, to our faculty, Dr. Rajinder Singh sir, Dr. Sanjeev Gupta, Dr. Deepak Tikku sir, Dr. Tarun Deep Singh, Dr. Hayat Ahmed sir, Dr. Haseeb Ghani, and Dr. Azharuddin sir for taking part in this webinar. Like Dr. Amit Vyas rightly said, the whole theme and the scheme of the webinar is decision making, and we try and do this through having an introductory lecture, and then we have a review article, and then case-based discussion, which kind of really enhance learning process, and is a very practical and a very hands-on way of learning things. So I think without further ado, we could begin with the webinar and the discussions thereof. Amiji, would you like to?
Sorry.
Yes, sir.
Ghani sir, I would invite Dr. Abdul Ghani sir to please say a few words before we begin the webinar. Thank you.
Well, at the outset, I'm extremely thankful to Dr. Abhijit, IO Hand Committee, Dr. Amit Vyas, and other members for providing us this wonderful opportunity to be interacting with you as a national level. And what a better topic than this, which we are dealing every day. And obviously, still, that is there are a few areas which are unsolved. I'm pretty sure after this webinar, the things are going to be much clearer. I'm extremely thankful to Dr. Altaf Kosa, our president, and of course, my faculty from JKO, Dr. Rajinder Singh, who is our ex-HOD, Department of Orthopedic GMC. Dr. Sanjeev Gupta is a present HOD GMC Jammu. He is also was ex-president JKO and ex-president North Zone Association. We got a very young, dynamic Dr. Deepak Tikku. He is chronologically not young, but physiologically very young. Dr. Tarundeep Singh, another young fellow, dynamic Dr. Hayat Khan. He is a member of JKO from Kashmir, but he is joining from Saudi. Welcome, sir. We have got one wonderful young talent, Dr. Hasib Ghani. In fact, Dr. Abhijit told me that we would like to hear from Hasib Ghani and you just coordinate. Dr. Abhijit, I hope I am correct in that. So they definitely, because of the
Absolutely correct.
hard-hitting discussion, he is very much in demand. And we got another one young talent from Ladakh, UT of Ladakh. Previously, they were used to be part of us, but unfortunately now they have they've defied us somehow and they split it from us because somehow I don't know why they did not like us. So Azharuddin from Kargil. So, I mean, they are going to be here. Both of them are going to be presenting some cases interesting. So, over to you, Dr. Abhijit, after this. Thank you.
Thank you. Thank you so much. I'm so happy to be amongst you all. And I was really looking forward to having Dr. Haseeb Ghani online because we have been discussing for some time and I found him to be incredibly kind of curious, inquisitive, and talented young colleague of ours. And this is a platform where we learn from each other. So without further ado, please allow me to, kind of present this. Uh, Introductory talk. Is my PPT visible to all of you, please?
Yeah,
Yes,
is
sir.
it?
Yeah, yes.
Yeah,
Yes, it is.
right.
Yes.
So, this talk will hopefully lay the foundation and the pathway for the discussion that we're going to have. And I'm going to talk very briefly and quickly about the approaches and techniques for what is called as fragment-specific fixation of distal fractures, and why this is perhaps a more reliable and a robust way of looking at distal fractures. And I do not have any conflict of interest regarding this talk. So this talk is spread out over these topics. We'll introduce distal radius fractures, recognize fracture patterns, and identify those that require fixation. We'll try and understand the different classification systems and perhaps zoom in and focus on a classification system that has lesser inter and intra-observer variability. Try and understand approaches and the anatomy which will help us produce and reproduce reliable and robust outcomes for our patients, understand some practical tips and tricks to fix these fractures and the caveats thereof. Now, I'm sure that we all have read this famous aphorism by Abraham Colles, right from our days of residencies, and even today, we believe that once a distal radius fracture has united, it will very seldom, cause any problems, and more often than not, people will do well. But we need to understand this was something which was mentioned in 1814, and we really need to ponder upon whether this is still true in 2026, wherein we have longevity that is more than it was in the 1800s. We have high velocity trauma, and we have people who have sports and um, activities that require usage of the hands at the earliest possible. Now, again, all our senior colleagues, my teachers, and of course, a few of the younger generation also would have either seen or read about the evolution of the management of distal radius fractures, right from using casts, reduction in casts, to pins and plasters, pins and fixators. Then came in your volar locking plate. Then you have fragment specific fixation. And what you see on the extreme right of the screen is what's called as a sonoma nail. It's an intramedullary nail for treating distal radius fractures. However, whatever modality we use for fixing or treating distal radius fractures, the goal of treatment is standard and universally the same, and that is to restore the anatomical relationships when and if possible, to maintain fracture reduction until the fracture is united, and of course to maximize the outcomes while minimizing the complications. And therefore, we need to understand what is called as the column concept, which was introduced by Rickley and Regazzoni, which basically forms the fundamental basis of what is called as fragment-specific fixation, which was expounded upon by Geisler and Fernandez and other authors that are listed on this particular site. Now, before we delve further into the nuances and the details of this aspect, let's understand the determinants of treatment, and we all will perhaps conquer that fracture characteristics, patient factors, as well as surgeon preferences are going to determine the actual outcome for our patient, but we still do not know which of these factors is the most important. So with that behind us, we'll try and understand the unstable fracture patterns that will require fixation. We need to understand and recognize if there are any guidelines in literature to help us do that. And of course, surely enough, we have the AAOS guidelines that were published in 2009 by Nerk and Jupiter. And they said that any displacement of more than 2 millimeters with a post-reduction radial shortening of more than 3 millimeters and a dorsal tilt of 10 degrees are inherent indicators of instability, and therefore these must be fixed. But way before that, in 1989, LaFontaine came up with these 6 criteria, which perhaps are more reliable in determining instability and fracture patterns that will require fixation. However, to understand the classification systems and to apply them, we all know there are so many of these, and I think I'm not a great fan of classification systems because I simply cannot bring myself to remember them. But we need to understand and recognize that every classification system has been shown and demonstrated to have a considerable amount of inter and intra-observer reliability, and there is a lot of variation that is associated with these classification systems. So is there a classification system that will be easy to recall and to reproduce, which will help us correlate the fragments that we are seeing on these 3 X-rays consistently, and also perhaps on other investigative modalities such as a CT scan? So for example, these fragments, can we correlate them consistently on a PA, an oblique, and a lateral view? And that is where the column concept comes in. Very simplistically, the columns of the wrist are classified as the radial, the intermediate, and the ulnar column. And the intermediate and radial column rest upon what's called as a pedestal, which is essentially the diaphysial-metaphyseal junction. So other than the radial and the ulnar column, the intermediate column has a little bit of a nuance to it in saying that there is a dorsal wall, a volar rim, a dorsal and a volar ulnar corner fragment, 3 intra-articular fragments, and metaphyseal defects. So if you remember this classification system, it becomes very easy to correlate the system, the fractures. Not only that, we should now also recognize that distal radius fractures are essentially osteoligamentous fractures. And when I say this, please be reminded that I'm talking about the intra-articular fractures and not the extra-articular fractures. So there is a very consistent pattern of these fracture lines, which are fault lines, which kind of run between the extraosseous ligaments of the distal radius and the carpus. So you have these fracture lines which run between, for example, the long and the short radial lunate ligament, the radius scaphocapitate ligament, and so on and so forth. And the preponderance of these fractures has also been studied. And there's a very nice paper that you can refer to and read at your leisure. So when you look at the same slide that we saw earlier on, and you were to again correlate with the CT scan, it now becomes very intuitive to correlate the fragments both on the X-rays as well as the CT scan once you follow the column concept. And the fixation or the treatment of these fractures again is conceptual in stating that the stable fixation of all columns and components should be achieved while starting with the simplest technique, and then you advance these techniques as and when required. So if you were to see this schematic diagram on your left-hand side, an ulnar corner fragment on the volar side would require a plate only for that fragment. If there is a radial involvement, you would then use an additional implant. If there is a dorsal ulnar column fragment along with the radial column fragment, you would then do a permutation and combination of these plates. So here's a case in point. The PA view looks quite innocuous until you look at the lateral view, and you'll appreciate that there is something going on here. There is a lot of combination, and the CT scan then adds a little bit more of information to those X-rays in that there is a central metaphyseal, central intra-articular fragment which is incarcerated. So you elevate that, you fix that, but you please realize that the intermediate column has been addressed and fixed, whereas the radial column is still unaddressed. How do you do that is then you add an additional plate on the radial column, a dorsal plate to address the dorsal column fragment, and you have a beautiful restoration of the anatomy and function that will be quite appropriate for this patient. Another case in point, you will again see that these look quite innocuous until you pay attention to this ulnar corner fragment, which looks quite ominous. And then if you look at the actual CT scan, there is a very small, tiny little dorsal corner fragment. The problem with this is that if you were to use a plate to fix this and address this fragment, the purchase would be inadequate. And two, you would risk having your screws intra-articular into the radiocarpal or the radioulnar joint. How do you deal with this? Is that you fix the intermediate column with a volar plate and you buttress the dorsal ulnar corner fragment with a dorsal approach. So, like I said, we have approaches that we need to understand. The volar standard Henry approach, which has been modified by Orbe using that little dart distally, allows you greater access distally. You elevate the entire pronator quadratus in a reverse L manner, and then you also elevate a flap of what's called as a transient fibrous zone. We'll just see that in a little bit, and you have a beautiful exposure to the entire distal radius. Another utilitarian approach is what's called as the volar ulnar approach, which is between the palmaris longus and the flexor carpi ulnaris. Here you retract your ulnar neurovascular bundle ulnarwards, whereas all the flexor tendons go on the radial side, and then you approach the fracture and then use these plates to reconstruct your teardrop. Of course, you may use different anatomical plates to fix these fractures as and when required, as is seen on this slide. And of course, you have the dorsal approach, which is a very, very good approach. And I think every orthopedic surgeon should know this approach. Dorsal midline incision, your extensor pollicis longus forms the lighthouse to the approach. You exteriorize the extensor pollicis longus. After that, you raise full thickness subperiosteal flaps of the second and the fourth extensor compartments. Use the combination as a trapdoor through which you can approach, elevate the impacted incarcerated fragments, do your bone grafting, and then bring in your plates to fix so that you're able to buttress and reconstruct your anatomy just like so. What's important is that you close the extensor compartments over the plates in a manner that these plates will not cause irritation of the extensor tendons. So with that behind us, there are some tips and tricks that we need to understand. One of the most important tricks that I have learned is releasing the brachioradialis, which makes reducing the radial column styloid fragment very, very easy. Please note the marked flap here. That is a flap of the transient fibrous zone, as we call it. And once you have raised that flap, it allows you a few more millimeters of access to the distal aspect of the distal radius. How is that important is when we understand the anatomy of the distal radius plates. These two plates, for example, are two different animals and they behave as such. Take this fracture, for example, we have raised the flap here. The fracture is here. If you use this plate, the fracture essentially remains unaddressed and inadequately buttressed. Therefore, to use this plate, you need the real estate distally. So elevating the flap of the transient fibrous zone makes it ever so easy to place this plate and fix it adequately. There is always the question of the ulnar styloid. What should we do when we have distal radius fractures? Take this case in point. We have, kind of restored the anatomy of the distal radius. In pronation, you will find the styloid is sitting quite well, whereas in supination, the styloid is falling off. What it shows is that it's a great instability of the DRUJ, and then you can manage this either with suture anchors, hook plates, or with tension band wiring, whatever you would want to use or you fancy. Essentially, we should know that the DRUJ should be stable. There are certain caveats. These implants have their own fair share of complications if not used judiciously and erroneously. Tendon attritions, in particular hardware, are all looming problems. So, in summary, distal radius fractures are a favorite of every orthopedic surgeon, but they will continue to challenge us, and we need to understand our failures so that we can improve our successes. We need to carefully assess the fractures, and this is what will determine the optimal fixation. And we need to understand that it is a surgeon and our understanding of the fracture and how to fix it, and not the hardware, that will decide the outcome. So thank you very much for the attention and the opportunity.
Thank you, sir. Thank you very much.
Thank you.
Any questions from audience?
Dr. Rajendra Singh, sir, any questions from your end? We got very hard writing, strong, young surgeons, Dr. Rajendra Singh. He is going to give you a tough time, Dr. Abhijit. You
No
just need
problem,
to have
sir.
to bear with it.
Sure,
So
sure, sure.
over to Dr. Rajendra
Thank
Singh
you.
for any comment or question, sir. Sir, I don't think he's listening.
Or should we keep the question and answers to the end, sir, so that we can
Yeah,
finish off
that's
the webinar?
perfectly
Yeah,
fine. That's perfectly fine. Yeah, go ahead.
fine. Thank you, sir. Thank you.
So with this, I would invite Dr. Tarun Deep Singh uh, to present. Basically, he will present the what literature says, how to treat lower end radius, what are the recent evidences, and so he has summarized all the things.
Is my screen visible, sir?
Yes, yes, Tarun, it is about to come.
Yes.
Yeah, it has come.
Is the entire screen visible, sir, or just the window?
No, no, you need to go into presentation mode. Press F5 or go into presentation mode.
Can you go to slideshow, please?
Is it visible now, sir?
Yeah.
Yes.
Uh, Good evening, everyone. Not taking much time. First of all, I'd like to thank JQOA and IOA for giving the opportunity to talk on this very important topic. And I'll just present a review article that was published in a Journal of Clinical Orthopedics and Trauma. And the article was when a volar locking plate is not the right choice in fractures of distal radius, and it was a case-based technical considerations. Was published by Dr. Rohit Garg and Dr. Chaitanya Smudgal, and it is available online from June 8th, 2020. And to introduce, as Abhijit sir has very beautifully highlighted everything regarding DRFs, and it is one of the most common musculoskeletal injuries, especially in people who are osteoporotics. And there are a number of treatment options that are available. And however, the popular treatment choice has always been a monoblock volar locking plate. And but obviously, as sir has told that very often we are encountering some fracture patterns for which the volar locking plate is not the only and not the right choice. And we should understand which are those fractures for which some other option should be done. And so for that, we should be familiar with all the fixation tools that can fix the fractures according to the fracture fragment size, geometry, as well as the anatomy. So I will highlight some important anatomic features of the distal radius. First of all, just to tell you about the radial styloid, it extends volar, radial, and distal to the radial column. And the tip of the radial styloid, it lies volar to the equator of the distal radius articular surface. Therefore, when we are placing any implant from the tip of the radial styloid, we must target it ulnarly, but also dorsally, so that we have going to have good purchase in the proximal fragment. Next, as sir told that these are some fractures, especially intra-articular fractures, they must be considered as osteoligamentous injuries. So to highlight upon the RSL ligament, that is the radioscaphocapitate ligament, we must remember that it is attached around 7 mm from the tip of the radial styloid towards the volar lip of the radius. So whenever we have a displacement of the radial styloid, it inevitably leads to the displacement of the carpus. Next, very important, as sir told about the volar lunate facet, it always extends volarly, ulnarly, as well as distally. And to this fragment, it is attached the short radiolunate ligament. And whenever this fracture occurs, similarly, we have a displacement of all the carpus that this ligament gives attachment to. And next to coming on to the dorsal aspect, we have a dorsal ulnar corner of the intermediate fragment, which is known as the die punch fragment. It also bears attachment of the dorsal radiotracheal ligament. And sir, as told that these are osteoligamentous injuries, so these things must be kept in mind that whenever we are fixing these fragments, the ligament tensioning has to be very good, and these fractures must be fixed anatomically so that displacement of carpus in the future can be avoided and taken care of. In this paper, they discussed all those fractures, and they presented in all those patients they had a standard PE oblique and lateral radiographs of the wrist joint, and they obtained these X-rays before and after reduction, and CT scan was obtained in all these fracture patterns. But in CT, the particular attention was given to the fragment size, geometry, and location of the fractures, so that they are able to give a good implant and to decide which implant will be the best for them. And volar marginal rim fractures, especially in the volar lunate facet, dorsal rim fractures, radial styloid fractures, as well as any elements of articular depression. What they found was that, in their opinion, volar lock plate was not the suitable option for these four fracture patterns, especially when, number one, there was a radiocarpal fracture dislocations, as sir told, or the volar Barton, or if there's a dorsal Barton fracture. Next was the dorsal rim fractures. Another was the scaphoid impression fractures, and last was the isolated lunate facet fractures. And the outcomes of the paper were that it's very important that you are carefully evaluating these X-rays before and after the surgery, and you are obtaining good pre-op CT scans. It's very important that you can plan the surgery well before, so you are well equipped inside the OT. For radiocarpal fracture dislocations, if there's a loss of 30 to 40% of the, if there was loss of around 30 to 40% of the flexion extension arc. However, they also found that there were worse outcomes with persistent articular incongruity. As Sir told, that anatomic reduction is very, very important, and worse outcomes were also reported with the other, if the DRF was associated with other carpal fractures, or if there was an ulnar translocation of the carpus, especially when there's an associated RSL injury. And post-traumatic arthritis is commonly seen if you are not fixing these fractures well, because it can lead to intercarpal instability and as well as arthritis in the future. The pearls, I would discuss four to five pearls. Number one, pre-op CT scan, especially if you are going for a 3D recons, it's very important for your good treatment planning. Number two, one needs to be aware of all the common approaches, as Sir told about the different approaches that you can use to utilize to for the fragment specific fixation. Number three, a dorsal spanning plate is considered additionally as a adjunct to protect the tennis or the bony ligament repair. And number four, DRUJ stability. As Sir told, when we were doing the DRUJ allotment test, if there's associated any ulnar styloid fractures, then DRUJ stability should be assessed at the end of each case, and you are checking it on table whether it's unstable in supination, pronation, or in neutral rotation, and you are fixing it in the same go. And last, it was very important that they found that careful contouring of the dorsal place was very important. So you are avoiding dorsal tendon irritation. And an important pearl, that subperiosteal dissection is very important, especially between the second and the fourth dorsal compartment. It's very important. So you are able to cover that very well over the plate. To conclude, the paper volar lock plating has become the most common type of fixation for DRFs, but there are many fracture patterns that we must recognize before the surgery by doing good CT scans in some scenarios, and in doing good pre-op X-rays, as was outlined in this review, and to understand which fracture patterns are not the right ones for just a volar lock monoblock plate. Thank you.
Thank you. I think you can end your slideshow, Tarun,
Yes,
and
sir.
we can, Gani sir, shall we?
Hello.
Proceed. Shall we
Uh,
proceed with the case discussions, please?
yeah, we can actually.
Yeah.
Dr. Azhar, can I request you to present your case? Dr.
Yes,
Azhar,
sir. Yes, sir.
okay, over to you.
Is my screen visible to all?
Yeah,
Yeah, good
Yes,
evening
sir.
to all. I'm so happy to be amongst this great orthopedicians that we have all across our country. And I'm highly thankful to Dr. Altaf Kausa, sir, Dr. Sanjeev Gupta, and Dr. Abdul Ghani for giving me an opportunity to be a part of this August gathering. So basically, I'll be talking about KVAS in distal and radius fractures. I'm Dr. Azhar. I'm a consultant orthopedics at working at District Hospital Kargil, and this is our beautiful hospital, which looks like this in winters, totally cut off from the rest of the country. So we all know about the history of distal and radius fractures. It started way back before the discovery of X-rays and the famous lines of Abraham Colles. So these are the guidelines that were published by British Society for Surgery of the Hand in 2018. And so there are some of the things that were said in this in this book. So they found that there is level one evidence that there is no evidence supporting any treatment option for patients who are less than 50 years and up to 65 years of age. So another thing that was seen is that patients who are more than 65 years of age, there is evidence that operative intervention does not provide a superior outcome to non-operative management when they are measured by post range of motion at 1 year of age. The same findings were there by American Academy of Orthopedic Surgeons as well. So there are uh, uh, there are multiple radiographic parameters which affect the functional outcome. The most important of them would be ulnar variance and dorsal tilt, more than what radial inclination, radial height is. So here there is again for the outcomes in different age group, in the age group of 38, 58, it is seen that the ulnar variance and dorsal tilt, they are the most important parameters that decide the outcome of the procedures that we do. So decision making, there are a lot many factors that play an important role in the outcome of the fracture management. There are patient specific factors, there are surgeon related factors and fracture related factors. All of them I have read, I've tried to put in a slide. So whenever a patient comes of a fracture of distal end radius, these are the four questions that I ask. Is the fracture displaced or undisplaced? Whether it is intra-articular or extra-articular? It is whether it is reducible or irreducible, or whether it is stable and unstable. So depending upon that, I have tried to simplify the fractures into two groups, undisplaced and displaced. Undisplaced, it's a cast and weekly follow-up x-rays for 3 weeks. If it is displaced and reducible and the reduction is stable, we convert into a cast. If it is reducible but unstable, we do a closed reduction internal fixation. And if it is non-reducible, we'd have to do an open reduction internal fixation. So non-operative treatment, there are lots of, these are the indications for that. A short arm cast or a splint will suffice for 4 weeks. Another interesting thing that came about in this book that was published by British Orthopedic Association of Society of Surgery of the Hand, they said there's level one evidence when they compared KVAS versus open reduction internal fixation for for dorsal fractures. Open reduction is not superior to KVAS fixation when measured at by the post-operative range of motion at 1 year of age, and so they
Dr.
recommend.
Azharuddin,
So,
I'm very sorry to interrupt,
sir.
but PROMs is patient-reported outcome
Okay.
measures.
Sorry.
Yeah,
Okay.
PROMs. No, that's absolutely fine. Thank you.
Thank you for correcting, sir. Okay. So what are the principles of doing a closed reduction internal fixation will be, these are the ideal candidates, young patients, patients with dorsally displaced but reducible fractures, patients having radial shortening of 5 millimeters, radial inclination of less than 15, dorsal tilt of more than 10, ulnar variance of more than 2, intra-articular step of more than 2 millimeters, and more than 65 years of age. So when we in the last 2 decades, the go-to surgery for distal and radius fractures would be plating of the fractures. But we have more than 100 plate designs, and there's a lot of confusion in their availability and which plate to apply in which scenario. Also, the most important thing is about the cost of these plates that may range from a meager 5,000 to a max to 50,000 Indian rupees. So India is a different scenario where you can see on the same road, people would drive on a bullock cart as well as the people will drive a Ferrari. So this is a photograph of Mumbai where you can see a clear demarcation line between the urban and the rural area. So the demands of the people of these two places are different and unique in their own aspect. So working in a metro city, in a city where we have a wide variety of resources, a lot of implant availability, and working in a city which is a tier 3 or tier 4 or a rural area, a lot of things they hinder the management in the management of fractures. Here the implant availability is limited. The choice of implant is based on the availability and the affordability. The decision making is not driven by evidence but rather by resource driven. Cost factor is a major limiting factor in the places where there is people having a lot of a poor background. So intra flexibility, in a metro, we'll have a multiple backup options, but in a tier 3 or a tier 4 setup, we have very limited options. So there's a lot of differences between how we look at things in different places. So similar to something like this, asking different animals to give the same exam. So if we think about KVAS, the thing that comes to our head would be an extra-articular fracture, which is unstable and which is made stable by putting KVAS. So at Cargill, because we do know the nearest vendor that we have for implants is situated around 250 kilometers from the place where I work. We do not have a single vendor who would give orthopedic implants here. And even if we order an implant, it would take at least 2 to 3 good days for it to reach us if the road is open. So in our place for the comminuted high velocity injuries, distal and radius fractures, we have resorted to perform close reduction internal fixation with KVAS. I'll quickly share some of the cases that we have done here. So this is a young foreign lady. She's from Netherlands. She had a road traffic accident, and you can see there's a distal and radius fracture and ulnar styloid. We did close reduction internal fixation. We put 3 KVAS and put a slab. She had a boyfriend who also had a fracture of the humerus, which we treated. The only thing that was done at Netherlands when she went back was they converted our slab into a beautiful cast like that. And this was her hand at the time of pin removal. And this is the X-rays that she sent me from Netherlands. See the healing that has taken place in around 5 weeks. Another case, a young male who had a bad road traffic accident, highly comminuted the fracture of the distal and radius with dorsal comminution. This is his hand, how it looked. So we did something like this, and we had put in a lot of KVAS, and this is how his hand looked in an X-ray in the post-op at 3 weeks. I could not get his X-rays at the current status, but I could manage to get his function of the hand. He's basically studying in Punjab, and this is his hand status as of now. Another person who had a comminuted dorsally displaced fracture, and what we did is we did a close reduction internal fixation with KVAS. These are the X-rays in the follow-up, and this is the final X-ray which was taken at around 6 weeks. The case 4 here, we had a 55-year-old carpenter who had a fall, and this was his dominant side. See how badly comminuted his radius looks. So we didn't had a CT scan to be that time. This case was done like 2 years back. CT scan was not functional. So the parameters that were there. So what we did, we gave a longitudinal traction. This is how the fracture looked when we gave a longitudinal traction. And then we tried to secure the reduction that we achieved with the help of the KVAS in these sequences. And this is what we were able to achieve. This was how his radius looked at 3 weeks. And this is his 1 year follow-up. So this person, he's very happy and he's able to do his daily chores. And then this is the X-ray at the start on the left hand of your screen, and this is his X-ray at 1 year of the surgery. Another case, so a 30-year-old male who had a road traffic accident of his dominant side. It was very comminuted. So here we put KVAS, but in addition to that, we also have put a transarticular external fixator. And this was a CT scan was done post-op in order to see whether the fracture was put in a good place or not. So this is his X-ray, the initial X-ray, and this was his X-ray at around 7 weeks when we had removed the instrument, the fixator. So this is our experience at Kargil. We have done around more than 100 cases, or a spectrum of wide variety of fractures, including complex comminuted fractures of the distal end radius across various age groups, from 13 to 68-year-olds in the last 3 years. All of them were treated with close reduction internal fixation with multiple KVAs, and some of them we had put an external fixators. We are going to soon publish it in a paper, but so the most important thing about the presentation that I worked or what I've learned is that there's no clear consensus on the management of these fractures. The goal is to restore the congruity of the radiocarpal and the distal radioulnar joint surfaces, and to restore and maintain the length of radius. Osteosynthesis using K-wire fixation is a reliable procedure for dorsally displaced distal end radius fractures that cannot be stabilized by casts. It may be indicated for certain type of intra-articular fractures. It has the major advantages over plating in terms of cost and invasiveness. You can clearly compare the two bills that you can give to your patient, a bill of around 50,000 to 2 lakh rupees versus a bill of 200 to 500 rupees. So I would like to conclude with this, and I would like to thank all the senior faculty for patient listening. Thank you.
Wonderful. Excellent presentation, Dr. Azhar. Can you stop sharing your screen?
Yes.
Dr. Abhijit, can we go to Dr. Hasib Ghani for his presentation of few cases?
Yes, yes, sir. Of course, certainly. Thank
Okay.
you.
Dr. Hasib Ghani, much in demand. Over to you.
Thank you very much, sir. Can you hear me?
Yeah, we can.
Thank you for this kind introduction, for engaging me in this event. Thank you, Dr. Abhijit. It's very kind of you to have given me this opportunity and think that it was worth. I think the people I'm addressing are way more qualified, and I think Azhar has shown that there are. I think everyone's a better surgeon than me. I just feel a bit embarrassed now at my two cases. I'm not going to delve into the details of the distal radius fracture philosophy. I have put together some slides of
Dr.
a couple
Ghani,
of
just a
cases that
moment. I
I've done.
think Dr. Ghani, I'm sorry to interrupt,
Yeah.
but I think Dr. Azharuddin hasn't stopped sharing his screen.
I will. Azhar, Dr. Azhar, can you stop sharing screen?
I'm trying to find how to unshare my screen.
Just
Sorry for that.
so no, just take your cursor up to the top of the screen. There is a floating screen out there,
Yeah.
and it will say end share. There's a little red box. Yes, it's done. Thank you.
Thank you so much. Thank
Thank
you
you.
so much.
And I request everyone to please keep themselves on mute when someone else is presenting. Dr. Amit, if you are still around, can you please mute everyone, and only Dr. Ghani will be online. I mean, will be speaking. Thank you.
Hasib, can you start sharing your screen, please? Hello. Yeah. Someone is not muted himself. Hello.
Sorry, I lost connection for a bit. I'm going to share my screen now.
Hello. Dr.
Hello.
Amit Vyas, please make me co-host, or you please mute the other mics. Thank you.
Okay, Dr. Hasib, start actually automatically.
Can you see my screen now, sir?
Yeah, we can.
Yes.
Hello.
Yeah, we can.
Okay, good. So my first case is a 40-year-old man who is a carpenter, and he injured his wrist while he was at work. It was his non-dominant hand. It's closed fracture, and it was put in a plaster close to where he lives. And he came to me at 5 days, and his question was, when can I get back to work? And this is the X-ray he came to me with. Herniated fracture with an extension into the joint. And to me, the most remarkable thing about this fracture is that, which is the harbinger of instability. And it tells me that however well I reduce this fracture in a plaster, it is never going to stay that way. And here I have a 40-year-old manual worker who needs to be at the best of his game to be able to make a living. So this needs fixation. So he came with a CT scan. I don't know if you can make out the details. I should have magnified this a bit. But the one on the left shows the area of metaphyseal comminution dorsally, and those axial and sagittal cuts show the dorsal tilt, the comminution, and the articular extension. Fortunately, there was no articular step off.
Dr. Ghani, your CT
So
scan slide is not.
I decided to.
The CT scans, the slides are not moving.
So they are static images. They're not videos. Sorry.
No, the slides. Saying that I can see only the X-rays.
Hasib, your slides are not moving. It's only the first slide we are seeing
okay.
it.
Hang on.
There's some problem with the network, I think.
Maybe. I've tried to disconnect all other devices.
Dr. Ghani, if your network is not good, you can shut off your video actually, so that it'll increase the bandwidth
Hasib,
for your PPT.
Yeah, I'll do that.
That's good.
Yeah, okay. Thank you. Where's my... Can't find my presentation. Okay. Can you see the slides now?
No.
Click on your presentation, Dr. Hasib.
Yeah, I am on my presentation.
Your screen is visible, but your presentation is not available.
Okay.
Stop sharing and again reshare, Dr. Hasib.
I'll probably do. Yeah, sorry. I'll try once more, and if it doesn't work, I'll just disconnect from my Wi-Fi and use my mobile data. Just give me one more chance.
Dr. Hayat Khan has a question till we have Dr. Hasib's PPT. Can we take that question, please?
Good evening, everyone. I am Dr. Hayat from Saudi Arabia right now. Am I audible?
Yeah, you are.
Actually, I just want to utilize this time till Dr. Hasib gets his network issues done. This
Can
was
you
nice
see my slides now? Sorry, Dr.
Yeah, you
Hayat,
can.
I didn't mean to interrupt.
No problem, no problem. I will
Okay,
get back
finish
to
your
you
question
later
and
on.
then
You can proceed with your presentation. No, I will get it later on. Just finish the presentation first.
okay. Thank you so much. Can you see the CT slides now, sir?
No,
No.
still can't. Still can't.
Anyway, can you go ahead with your slides first, Dr. Hasib?
Is that better?
Not available as yet.
Dr. Abhijit, meanwhile, I think we could start taking question because time is also running out. There is
Yes.
an issue.
Or if do we have any other presentation from anyone?
There is a presentation will be coming, I think, from one of the presentation is from Dr. Surya Dev, Aman Singh. So if we can quickly, Dr. Surya, can you start sharing your screen? Yeah.
Good evening, esteemed faculty across the nation. And I thank you for giving me the opportunity to present on this platform.
Any issues?
I'm not able to share the screen.
Okay.
At the bottom of your Zoom window, you have the share button, share option, and then from there you could perhaps try and share.
Should I try doing mine? What or
Anyone which works.
Yeah, see if you try.
okay. Can you see my screen now?
Yeah, can you start moving the slide because the problem is movement.
I
Yeah,
think it should
moving
happen
slide.
now.
Yes.
Yes.
Yeah.
Yes.
Okay, good. So sorry about that. You can see the comminution and the fracture configuration on the CT. And based on this, I plan to do it via a Vola approach using a standard Vola locked plate. This is a fairly standard design. It's a Synthes 2-column plate. This is not a Synthes plate, it's a lookalike. These are my usual steps. I usually don't use a plate longer than 3 holes. Sometimes I'll make do with a 2-hole plate because that's all you need. The fracture fortunately could be pulled out to length, and we can appreciate in this AP view the extension into the radiocarpal joint close to the radial styloid. So I position my plate and I take a little lateral view and see if I'm positioned appropriately in terms of proximal distal, and I'll put in a K wire to stabilize the plate at that level, and then I usually put in one or few screws with the distal end of the plate flush to the volar cortex. In this case, the volar cortex was not very much displaced. It was dorsally angulated because of the dorsal comminution. So this is how it looked after putting in a screw and a KY. This is my usual tactic for which helps me reduce the dorsal tilt. And I also use the plate as a reduction tool to help get the tilt back and also restore length. So I'll put in a few distal screws as is seen, and I'll usually fill in the distal row like this. And at the end of that, the lateral view will look like the image on the right. The plate is off proximally because it is an anatomic plate and it is meant to fit to the volar contour of an intact distal radius. So I fit it to the distal radius distally, and then when I put in a proximal cortex screw, the distal block gets pulled by the plate, thereby restoring the volar tilt. And when I do this, I also I apply a distraction force so as to restore the fracture length. And I have found that this works really well for most fractures. And it doesn't work always, especially if there is volar comminution. But for me, this is the go-to step, and it saves me a lot of time. I don't have to hold the fracture. I don't use many KYs for provisionally fixing. I don't try to hold the fracture with my hand. I just let the plate do the work. You just need to follow a few steps. So this is how the fracture looks at the end. That's a PA view. You can see the distal radio-ulnar joint is congruent. There's no screw penetration into that joint. There is that styloid fracture which did not move with pronous supination, so I left it alone. That's the lateral view, and on the right is the sunrise view, which I see. We don't want to leave screw tips too proud dorsally. That can irritate tendons. This is this guy at 6 weeks. The fracture is healed. Even the ulnar styloid bit looks to be healing. He's now 3 months out, and he hasn't come back yet. So yesterday I did a video call, and I asked him to do these weird hand movements, and he sent me this from his workplace. He's actually somewhere in the hills, actually doing some farming job. Fairly happy. Yeah, so this worked for him. My next case it was a little more complex than the previous. He's a 50-year-old banker who was in a car accident. Again, his non-dominant wrist, it was a closed fracture. These are the only X-rays I have from him, and he's got an ulnar styloid fracture. It's a type C. I think a C2. This would qualify as a C2. It's got everything. It's got the volar lunate element. There's a CT scan scrolling on the right. You can see there is dorsal comminution. There's a separate dorsal lateral and dorsal ulnar fragment. There's a volar ulnar fragment. There's a main radial styloid, and there's an ulnar styloid fragment as well. These are the 3D still images to help you get a sense of what is where. On the dorsal side, I really like Dr. Abhijit's presentation. I think it was so crisp and so beautiful, and it just captured everything, the nitty-gritty details, and what's important in these fractures. And that's the dorsal ulnar fracture that's so hard to control and yet so important in these fractures. And there on the volar side, I think this is probably the easier bit. The volar ulnar fragment is fairly large, which is a good thing. So this is something that you can capture with a standard volar plate, and the radial styloid fragment as well. But this is how it looked like when I pulled it under image. So pulling is not aligning it. If you see in the lateral view, so that's how osteoligamentous injuries behave. They don't always align when you pull them. So my first move was to restore the dorsal ulnar fragment, because I think that was the most unsupported bit. And my sense is that this is where we start, and then we work to it. Once you stabilize it, then you restore everything to it. So I took a fragment-specific plate from a dorsal approach. put in one screw just to buttress that fragment so that it's stable. And then I opened on the volar side. From the volar side, it took a bit of fidgeting to get everything right. And finally, I think most of the moves, my sequence of volar plate fixation was fairly mostly the same as I do in all cases. And at the end of this, I was able to get him looking like this. I think we managed to restore the anatomical relationships that Dr. Abhijit so eloquently emphasized. I think that should be the cornerstone of all surgical practice, whether we decide to operate or not operate. Restoring anatomy is paramount. Only when we restore anatomy can we expect good function in a predictable manner. We might get away with good function in a non-anatomic joint, but that is not predictable. That is a chance. So our job should be to restore anatomy to as near normal as possible. So this is him at 10 weeks. His fracture is healed. His ulnar stellate is still in the air, but he's not symptomatic and he's got decent range. He's a few months out now. He's not coming back, so I assume he's happy. I had warned him that he might need removal of that dorsal plate if it starts hurting him, but I have not heard back from him so far. Those were my only two cases. I'm sorry, I don't have more.
Excellent presentation. Dr. Hasib, can you stop sharing your
Yeah, I
screen
can.
so
I
that
just
Dr.
need to. Okay.
Go to the top.
Yeah,
Great,
got it.
thank you.
Dr. Surya, are you there?
Yes, sir. Sorry, I'm not able to share the screen, sir. There is some, I guess, some problem.
Are you able to present or no?
Sir, I'm not able to share the screen. So I guess there's some problem with the Mac or the software.
Okay. So then I think, Dr. Abhijit, we will start taking questions. Meanwhile, Surya, you send presentation to me. I may share this WhatsApp me, right?
Sure, sir.
Thank you. Dr. Hayat.
Hello, good evening again. My actually questions, a comment rather than a question to Dr. Azhar's presentation. I was he reminded me of 2014 when we were in the floods in Srinagar and I was working in Bone and Joint Hospital. Hello?
Yeah, I'm listening, sir.
Okay. So we were actually working in the floods and what we had, actually the electricity was not there and we had done many cases using the K-wires only. So we even did intertroch fractures by using the external fixators.
Okay.
For the first time, I think we were using that in the geriatric patients where we had a lot of comorbidities. But this flood period was very pathetic for us. So you are not alone. We are with you. Second thing is during the 2016 turmoil, we again had the same problem because we were under curfew for 5 to 6 months.
Right.
So, and after that, what we did actually was, that is important. We, for the distal radius fractures, we came out with a classification that is called Berzula working classification. It is available in the PubMed.
Okay.
You can go through it, and I am one of the authors. It was published under the supervision of Dr. Munir Farooq, professor, the retired now. And I think Dr. Altaf Kausa is also, he has also joined. Good evening, sir. He is not here.
Good
Anyway,
evening, Dr. I'm here. I'm around.
Oh, okay. Thank you, sir. So it was published by Dr. Yunus Kamal. He is right now the head of Department of Government Medical College, Anantnag.
Right.
So we proceeded with the classification. We published it first in the PubMed, I think Archives of Trauma, and then we published in the Journal of Hand.
Okay.
Journal of Hand, we published the intra-observer and inter-observer correlations. Or that is, I think, the same thing what you were actually mentioning, that we have stable, unstable, then where you need the open reduction, where you want to put the fixator. I think we collected, I think, somewhere around more than 1,000 cases.
Wow, that's great.
And that is not great. Actually, if you go to the Bone and Joint Hospital and you check, this is actually not the, I don't consider it as a hospital. I consider it as a university.
Exactly.
Because there are a lot of cases there. You just need to go there, sit there for 1 week, and you will come up with a book. But we are not doing that, unfortunately. Meeting Dr. under the guidance of Dr. Altaf sir there, they can do miracles there. Second thing, what I want to say is that once you mentioned that after 1 year, the patient's range of motions, the patient related outcomes were similar.
Yeah.
What I have seen over a period of time, because I have left Kashmir one decade back, I came in Saudi Arabia in 2017. It is not about for the patient, it's not about after 1 year what he is going to see. It is during that 1 year what he is perceiving. Your every fixation is dependent on your either on your X fix or on your cast.
Right.
What if a patient tells you, I don't want a cast? That is what we are facing. If you operate a patient and you put a back slab, he doesn't want it. So we should have an answer. It is not about, I want to put a cast because I want to give the rest to the soft tissues. You put a plate, patient doesn't want a cast. What we will do? We have to have an answer. I am very happy with your presentations. Thank you very much.
Thank you so much. Actually, I got hold of him after 1 year of time. In the time, I requested a lot. I requested him a lot many times to do visit me. He said he's doing fine and all. One fine day, his son came to me. I said, I'm not going to see any of your patient unless you bring your father to me, and I have to check his range of motion. So I got hold of him after 1 year of age, 1 year of the surgery. That's why I came to take the photographs.
Very,
And he
very
told me
nice
he was
job.
doing fine in that period as well. Thank you so much, sir, for your nice comments. Thank you so much, sir.
Welcome.
Great. Dr. Abhijit, sir.
Yes, sir.
Can we just quickly take some comments or questions from Dr. Rajendra Singh, very senior person and very keen person
Yes,
involving in a lot of discussions. So obviously, we don't want to be keeping him away from the discussion. Can we?
yes,
I am very much
yes, please.
impressed.
Dr. Rajendra sir?
Yes. Am I audible now?
Yes, sir.
Am I audible?
Yes, you are.
Yeah, of
Yes,
course.
sir.
So, very much impressed with the cases presented by Dr. Abhijit and others. The cases which Dr. Abhijit has presented, one cannot treat with KYs or chloro reductions. The cases which Dr. Hasib has presented, of course, they needed fixation with platings. Cases which were presented by Dr. Azhar, my dear. Hello?
Yeah, we can
Those
hear
are the
you.
cases which are fit for chloro reduction and KY fixations. Now, regarding the comments of Dr. Hayat, sometimes we don't have to depend upon patient's choice. We have to tell the patients the advantages and disadvantages of chloro reduction K wiring versus splitting. Am I audible? No?
Yeah, of course.
Yes,
Please
sir.
go
Yes,
ahead.
sir.
So, if the patient dictates to us, do me a plating, with case which otherwise can be treated by chloro reduction K wire only, I think it is not justified. You have to tell the patient that by doing chloro reduction K wire fixation, what the advantages you will have. And if I do open reduction and multiple plate fixations, you have to enumerate to the patient the complication which plate while doing plating or while removing plating or any complication or because of infection or implant failure can occur. If we tell the patients the good effects of close reduction and K-wire fixation versus good and bad effects of plating and open reduction, patient will understand. And most of the patient will choose the side which is safer, easier, and for which is good for him. So, with you, I don't agree that we should get dictated by the patient. I want the comments of others also on this issue.
Can I
Can
say
I just,
something?
yeah,
Yes,
Okay.
yeah,
yes.
yeah, please,
So,
please.
sir, you go ahead. I think you're better placed than I am.
No, no. Actually, I just wanted to kind of echo what Dr. Singh has said. I think our job fundamentally as physicians and surgeons or doctors is to help our patients make informed decisions and partner in their healthcare. And I think what he essentially was trying to say was, counseling forms such an important part of the outcomes ultimately. You're helping the patient make informed decisions. You have already explained to him the pros and cons of the treatment modality and help him make the right decisions. So I think ultimately, if we fail in this aspect of preoperative counseling, no matter what you do, even with good outcomes, because see, until the time the patient has had the trauma and the fracture, he was living and leading a normal life, and then all of a sudden he has the injury, so he does not know what to expect. So even if according to the surgeon, the outcomes are very good, and that's the reason why the patient-reported outcome measures, which Dr. Azharuddin was alluding to, are so important because we need to understand how the patient perceives the outcomes. So it's very true that we have to counsel very carefully, and for that we need to have to spend time with our patients. That's all I want to say. Thank you.
Dr. Ghani, I wanted to make a comment.
Yes, please. Over to Dr. Sanjeev.
Yeah, the second case presented by Dr. Hasib, very nice fixation. But I think the Indian implants, very difficult to get good dorsal plates. The case that Dr. Surya was going to present was a similar case, and which routinely many orthopedic surgeons face. A problem is of comminuted distal radius fracture, which needs dual plating. So in that case, we did a volar plate and a dorsal 2K wires, which held the fragments well in place. So Dr. Abhijit, what is your take on these cases? Because you need to be very expert to put a dorsal plate without much complications on the dorsum of the wrist.
Point very well taken, sir. So a lot of times we too do the same thing. So once you have stabilized the volar cortex, you can buttress the dorsal fragments over the stabilized volar cortex. And we can use intrafocal wires like the Caponghi technique to achieve that, or you can use K wires and joystick the fragment and then get some fixation and purchase in the proximal fragment. But truth be told, you're very right in saying that not all of the times your dorsal plates would be as minimalistic as some of your MNCs or multinational companies would offer. But having said that, I think in recent times, as I have been looking around in the trade exhibitions, there are a few companies which are making reasonably good and low profile dorsal plates. But again, at this juncture, I would want to take this opportunity to reiterate what I said on the last slide, that it is not the implant, but the surgeon who accounts for the outcomes. So many a times, even if you have good plates, even if you have all the best of equipment, but if you fail to adhere to the basic principles of anatomy, dissection, and fixation, we will have problems. So bar that, kind of nuance, I think if you would have even Indian plates, and if you're able to buttress reasonably well, don't use too stout a plate, which does not contour to the to the dorsal contour of the radius. But I think we can improve our outcomes by understanding the nuances of the implant design. I hope that kind of addresses the question, sir.
Yeah. Dr. Deepak Tikku. Tikku, sir. Dr. Deepak Tikku. Dr. Altaf, are you back?
Hello.
Yeah, hello, Dr. Deepak, sir.
Okay, we saw some complex trauma handled very nicely. But my question is, do these experts sometimes face a dilemma whether to treat these fractures conservatively, some fractures conservatively or otherwise? Are there some situations? Can you share some X-rays or some for lesser mortals like us?
No. So we have all been learning from stalwarts like
See,
yourself.
the thing is, I'm sorry to interrupt you. I thought the topic was when to fix and when not to fix.
Dr. Abhijit,
Any situation where
Dr.
we can
Abhijit,
treat these people conservatively.
He is
We saw
number
good
two.
trauma, we saw complex trauma, treated very expertly. Ab kuch aur bhi something else.
Hanji,
Dr. Abhijit,
your question
sorry,
yes.
Dr. Abhijit, sorry to interrupt. Dr. Deepak Tikku is number 2 batsman. Dr.
Yes,
Anil is number 1. So he is not less than anyone else.
Sir, can I? Okay.
Yes, please. Please go ahead. Please go ahead, Hasib.
Oh. Sir, just because the 5 or 6 cases that were shown were treated operatively does not mean in any way that we do not believe in non-operative treatment. It is just that I'll speak for myself. Maybe others may have different thresholds for resorting to surgery. But the evidence even today is, equivocal. I think one of the biggest series that we have about this, the risk trial that came out in 2020, which had 300 cases from treated between 2012 and 2016. They treated 180 with operation, 120 with a cast, and of those 180 operations, there were roughly 60 each of KVIS, an external fixator, and a plate. And they found out that 1 year, all the patients, all 300, had similar patient-reported outcome measures. Like they all behaved similarly. So if you go by that evidence, then I think like there's no need to operate on anyone, because that was those fractures did not include B type, partial articular, the shear type injuries. But that being said, I think we also have enough evidence and enough literature about how to assess the stability of a fracture. And that's how the step ladder is. If a fracture is inherently stable, which means it is just broken in two and there's no significant comminution, if you place it back to where it belongs with manipulation, even under local anesthesia, it will stay. And then you can reliably predict that this will stay long enough in a plaster to give a near anatomic outcome, and which will invariably lead to normal function. But with increasing comminution, complexity, more fracture lines, fractures become increasingly unstable. And so our strategy cannot be just pull them and put them in plaster and then hope they will all do well. They can all do well, but would we do that? Like, would we hope that way if we knew that there are other things that we can do to keep those fractures reduced and stable till time that they heal? So with increasing instability, especially in the younger patient group, I think there is enough like grounds for increasing complexity of surgery as well. You can, for example, a two-part fracture with just some dorsal comminution, you can treat with KVIS and a plaster. The purpose of the KVIS is only to counteract the displacing influence of the dorsal comminution. But if a fracture is split in three, and you're trying to get in a wire in all of the three fragments, you're going to be putting in wires for 1 hour and still end up with a construct which is not length stable. So the other thing is about how to the argument, and it's a valid argument. How do we balance the risks and benefits of non-op and operative? I think risks such as infection are overrated, because in my practice in 3 years, I've not had an infection in a wrist or in a leg, because surgical techniques have improved, implants have improved. The way we perform surgery has improved. So infection is a very, I think there's a higher likelihood of getting infection in a percutaneous KVI, which is not buried, than getting an infection after a plate, which is a well-done plate. So I guess what I'm trying to say is, we do plasters from time to time, but for me, I will only do a plaster in a metaphyseal two-part fracture, or which is mildly comminuted dorsally, and in a patient who is like, say, 70 plus, in whom some degree of shortening and dorsal angulation, even if the fracture collapses, would be fairly compatible in a predictable manner with a good functional outcome at the end of, let's say, 3 months.
Well, I would like to tell you a couple of things. See, if I see a fracture which is intra-articular displaced, lunate fossa fracture means again a comminuted fracture. A dorsal comminution, it would make me alert for more. I would go more in favor of operative. Now there are some, there are some other fractures also, which you can initially treat with a cast and follow up also. Do you do that, or you just, these some fractures you have to on the outside decide these have to be operated? You cannot. And there are so many others which you can treat with and wait. I mean, it would be very nice if you could have shown some. I mean, it's not only you, other faculty, that these were the fractures we treated initially conservative, and see what happens. I mean, this would give an insight into how this fracture behaves.
I really expecting some of this other faculty to come up with the non-op. So I thought that, I'm seen as the aggressive surgeon in the group. So I thought.
Can I,
Dr. Abhijit,
can I come in, please?
yes, please.
So, point very, very well taken, sir, Tiku sir, and I think I am very mindful of kind of the issue that is associated. But truth be told, uh, at the very outset, I pointed out the factors which tell us the instability patterns of fractures. Now, fractures which do not fit into those criteria and which are stable obviously will merit non-operative treatment. And I too echo what Hasib Ghani sir has said, that not one of the disclaimers I think that we should put out in the outset of this talk is that we don't operate on every single fracture that comes to us as a case. But then at the other end of the spectrum is also the truth that when you get into kind of a subspecialty training, most of the cases that come to us are referred cases or cases that are unstable, have been treated operatively elsewhere, and where say fracture fixation is perhaps a better way to go about it. So whole concept, the whole idea of the talk was to bring about awareness of those subset or that cohort of patients who will require fixation. And then therefore, uh, by law of deduction, all other cases will or can be managed non-operatively as well. So I hope
One more
I'm
small
able
question.
to.
One more small question.
Yes, sir. Yes,
Has
sir.
there been a change in your approach towards handling these fractures over a period of time?
Um, in which fractures are you talking? So the ones that require
Have
fixation?
you seen a change in fracture patterns? Have you seen a more complex trauma recently? Or, I mean, has there been a change in fracture patterns
Yes.
since the time you started working?
Yes, sir. So I think there is one addition of one thing there are two things that have really changed the way we deal with distal radius fractures. One is the advent of the concept of column concept and fracture specific fixation. And the second is the advent of spanning plates. So I don't remember the last time I've used an external fixator for distal radius fractures, except in the one odd case where you're doing corrective osteotomy and to maintain intraoperative length of the distal radius. But other than that, for these very tenuous distal radius fractures or rim fractures, which are very, very tiny, are very unstable inherently, we use a dorsal spanning plate. The concept was introduced by David Rouge out of the US. And what we essentially do is we use a spanning plate on the dorsal aspect of the radius and then some other fixation like K wires or a volar plate. And the dorsal spanning plate comes off at around 2 to 3 months, by which time the fracture has consolidated. So these two concepts have changed the way I deal with distal radius fractures, especially the very, very, very unstable ones and the very tenuous ones. There is one more concept that I learned in a meeting in Berlin. There is a German surgeon, I forget his name. What he does is that for these die punch fractures, wherein there is a lunate fragment, after reduction, he uses a radiolunate wire to offload the radiocarpal joint. So he keeps it for about 3 weeks. So that kind of offloads the radiolunate joint and helps in the union, or rather the fragment doesn't subside again, and that kind of helps in maintaining the fracture anatomy. So I think these are very beautiful concepts, and they have helped me in the long run. So
yeah, I think now over to Dr. Altaf. I think we are approaching the timeline also. We are already
yes,
20
sir.
minutes past what Dr. Abhijit has asked to finish the meeting when we still did not. So, Dr. Altaf. Hello, Dr. Altaf. President Trump, sir.
Just before Dr. Altaf comes in, I think there are a few questions. If these questions can be shared in the group that we had formed, then we will be able to answer these questions. Is that okay with Dr. Azharuddin and Dr. Omeshwar, who have asked the questions?
Sure.
And we could answer the questions in the group after the
I think that
session
sounds
is
good.
over. Thank you. I think Dr. Altaf, sir, has to address the meeting.
Is he around? Hey, wait a second. I'm just
He
going to
is
give
there.
you. Is there?
Altaf sir is there, but he's, I think, muted for some reason.
I think he has left. He had a call.
No, he was
Okay.
rejoined back.
Deepak sir, sorry, I'm sorry to interrupt. When did you last see a Colles fracture, a typical Colles fracture?
I do see them frequently.
Like purely metaphyseal two-part fractures.
Yeah. We're lucky to get them still.
I'm practicing in the wrong place.
Although, to be honest with you, I have very fixed criteria. See, if I see a lot of dorsal comminution, I tell them, bhai, even if I reduce it, it's going to go back. So it's not going to stay back. So if it is an intraoperative, say Barton or whatever, you have to tell them, bhai, surgery hoga. You can't do it otherwise. And you have a die punch kind of a thing. You can't do it conservatively. I mean, these are very clear criteria. Although, suppose now it's an older person, he impacted fracture, hai, and you are somewhere in the gray zone when the radial shortening is there, and the patient is 65, 70 or 75. ऐसे ठीक है भाई, शक्ल से अच्छा नहीं लगेगा, अकल से ठीक चलेगा, चलाओ उसको. This kind of a thing, but we are lucky to have simpler metaphyseal breaks.
I think it is a law of attraction.
Maybe the fractures choose their surgeons. I don't know.
Yeah, absolutely. That's what I want to say. I think Hasib is more attractive, young, dynamic, more smarter surgeon. Obviously, fracture will go to him.
Don't come to smarter. I think I'm still smart.
Is it?
One strategy would be, sir, to practice very far away from the highways. Your clinic should be very far away from the highways.
Shall we?
Yes, sir.
I think we can wind up if you want.
Yes. Is there a case presentation that you wanted to make, sir?
Just a quick one, because I thought why should I be left behind? So I'm not able to. Wait a second. So, can you see my screen? Hello?
Yes, sir. Yes, sir, very clearly.
Okay.
Yes, we can.
65 years old, right-handed dominant, 5 weeks old, injury close, and pain and limitation range of motion. Should we do something at this stage or not? That's the question.
Can I ask a question to this question?
Yeah.
So this is how many of the non-operatively treated wrists look. Yeah. Now, how do you? We know that these are going to end up looking like this and heal in this position.
Yeah.
And you have found this one who is in pain. So how do we predict at the outset that this guy or this person is going to settle into this position and still have good function? Because that's the traditional thinking. That's the logic. If it heals, it'll be fine.
So who's going to respond to that question? Of course, not me.
No. Answer is no. I can answer.
Yeah, of course.
The person practicing orthopedics should read the basic of orthopedics. He should know whether he is able to retain the radial length, radial ulnar variance, volar tilt, inclination, and rule out any malalignment. And he should see the step which is in textbooks. And the person who reads the textbook, he will go according to that. If his criteria is met, he will continue the same. If his criteria is not met, he will change the strategy. So these cases will rarely go on coming to us. Not only this case, cases who are well operated in good centers, they also develop complications. They will also go to somebody else. then he will blame surgery done by you. So this will keep on happening. So these are trickles which keep on coming to us, and trickles will keep on going from us also.
Okay,
Have
sounds
we
good.
answered well?
Yeah, Dr. Abhijit, what's your opinion on this?
Yes, sir. So as I see this X-ray in the PA view, I can see that there is a fracture of the radial as well as the intermediate column, and the ulnar column also is involved. When you look at the lateral view, I can see that there is a vertical shear fracture element involving perhaps the intermediate column, ulnar corner of the wrist joint. I think these are cases where, and perhaps there is a volar slight anterior-posterior distance of the distal radius is increased, and the carpus may sublux over a period of time. I would like to get a CT scan done for this to understand the anatomy further.
Okay, right, sir. So you want to further evaluation? Unfortunately, I did not have a CT, so I did something actually. So corrective osteotomy, bit of length restored, but I think there's still slight of inclination, maybe just neutral or maybe less than neutral. That's the only major issue to me. So any comment, Dr. Abhijit, on this?
I think you've been very successful in restoring the length and the inclination, but like you rightly said, the tilt is at neutral at best. But other than that, I think the parameters look reasonably good to me, so on this X-ray.
So this is what 6 weeks later, and subsequently, I think 3 months later, she was happy, and I was reasonably happy also. Yes, I think that was the major issue about the dorsal tilt, but other than that, I think reasonably maintained. So, any final comment on this, sir?
I see a lot of osteoporosis as if there are pseudodystrophy. Was it or not?
No, this X-ray photograph is not good, the last one. But before that, I think that was no, there was no RSD type picture.
Okay, thank you.
Clinically.
Thank you, thank you.
Yeah. So, Dr. Abhijit, any final comment on this, please?
Not really, sir, but if I look very carefully at the lateral view, I'm still not sure if there is a central depression. The range of what was the range of movement of this patient, sir?
No, I mean, subsequently she attained almost like 10 degree short of flexion and extension, but otherwise she
Right,
was,
sir.
I think, functionally very happy.
Right, sir. Right,
Yes,
sir.
Dr. Abhijit,
And the
I
DI
also
yes,
go
sir.
with you. I find some depression in the center,
Right, sir.
in the
But
lateral
I
view.
think if the function, yeah, but if the function is good, I think we can call it a good fixation. There is a comment in the by Dr. Kushor Dudhat that the plate seems to be a little distal to the watershed line, but if you look at the Zoom criteria, I think this is grade 0 to my eyes. I don't know if did she develop any problems with the flexors or of the any pain in the wrist joint? I don't know, sir.
I saw her around 2, 3 months ago, and that was 3 months follow-up. And at that stage, she was doing okay. And after that, she is obviously not come. If there's any problem, she is obviously going to come to me. This is a
Right,
regular
sir.
patient. So I think that's it basically. So I
So
would
I
stop.
Right,
think
sir.
Yeah.
sir, I think one of the points that Dr. Dudat has raised, it's very valid actually, and it circles back to one of the points or the questions that was asked earlier about the profile of the plates that we use. What you managed to get away with I think this is a 3.5 T plate, distal radius T plate, and it is a fairly bulky plate, especially if the patient is small. The screws are 3.5. They take up quite a bit of bone. They take up quite a bit of real estate. I think 2.7 plates are the way to go. I think 3.5s are a bit bulky, and they will
Yeah.
invariably end up irritating the tendons eventually, if not immediately.
Absolutely. Yeah, that's correct. Thank you. I think over to Dr. Abhijit for final words, and then we wind up.
Right. So once again, I'm very, very grateful to all of you, the JKOA, all those who took the time on a weekday and a weekend, week evening to be here to share their knowledge, their acumen, and the IOA especially for giving us this opportunity to network, to kind of collaborate. Dr. Ghani for taking the lead and doing this at such a short notice. Very, very grateful to you all. Thank you so much, and thank you for being on this webinar. And
Thank you.
I'm very grateful to the faculty also.
Thank
Take
you.
care.
Thank you.
Thank you.
Good night, all of you.
Bye bye.
Thank you.
Bye. Good night.
Thank you, sir. Good night.
Thank
Good
you
night.
all.
Bye bye. Bye bye.
Thank you, sir.
Bye. Good night. Bye. Bye.